Hi, everybody. Thank you for giving me the chance to participate in your academic half day. I promise I'll give you more than half of a talk. So for the next maybe 45 to 50 minutes, is it half hour or 45 to 50 minutes?
45 to 50 minutes.
Okay, great. So we'll talk about the acute coronary syndromes. Hold on one second, I'm sorry. Yeah. So as kind of a schematic overview of what we'll cover within the confines of the talk, we're really looking at the full spectrum of the acute coronary syndromes, which includes both those with and without ST segment elevations. So this is an electrocardiographic distinction. And indeed, if you think about how you're always going to approach the patient who's coming to you with an undifferentiated chest pain syndrome, a timely EKG is arguably one of the most important things that you can expedite for any of these patients, whether they're coming to the emergency department with an initial chief complaint of chest pain, or whether this is somebody that you're encountering in your capacity as an in-hospital intern on call, responding at night. Getting an EKG within 10 minutes of the voicing of that complaint of chest pain is really critical to understand what you're dealing with. ST segment elevation myocardial infarction certainly is something that has a certain set of responses and interventions that need to be executed very quickly to benefit and in some cases save the lives of these patients. And so that, of course, is very much its own thing. And you wouldn't know that it's the case without the EKG. We'll speak a little bit about ST elevation MI today, but most of what we'll discuss today actually will fall into the more common camp of acute coronary syndromes without ST segment elevations. Now, depending on what nomenclature you want to use, you can think of these as non-ST elevation acute coronary syndromes, or NST-ACS, or more commonly, we're thinking about these in the context of NSTEMI. Now, what differentiates NSTEMI from any other non-ST elevation ACS, of course, is the presence of a biochemical marker of acute myocardial injury, namely a troponin that's elevated. And so along with the EKG, we end up relying upon a troponin to make these broad diagnoses of myocardial infarction versus not, ST elevation versus non-ST elevation ACS. Now, as alluring as it is to set up the acute coronary syndromes in this way, I think all of us who have dealt with chest pain patients and ACS patients recognize that there are many shades of gray in between these big bins. And that's where some of the nuance comes into play when you're providing cardiology care for these patients. So you have to really believe that somebody's story is compatible with ACS. The classic example of this in my experience was getting called to the emergency room as a cardiology fellow for a chest pain evaluation in a patient who just got out of a fist fight in which he got slammed with a chair in his chest. And he said, "My chest is really hurting." And the ER said, "Do you want to take him to the cath lab?" You may do an EKG and not immediately see ST segment elevations, but again, much of the sensitivity of the basic EKG for picking up important ST elevations depends very heavily on where the actual electrodes are placed on the chest. Even with perfect placement of electrodes, you can have silent ST elevations, such as posterior wall MIs or right ventricular MIs. And there are cases that we've had where somebody really had a thrombotic total occlusion of a vessel that was completely missed on the basic EKG. On the other hand, sometimes the electrodes are not placed effectively in a way to even capture the extent of the territory you'd normally expect to see. So one of the most common ways that this is the case is that you'll see your V1 and V2 placed too high or too low on the chest, or you'll see the electrodes in the precordial leads kind of cramped together too much, so you don't actually make it all the way around to the mid-axillary line where you would want to be. And so just be a skeptic if the syndrome is very suggestive of a very severe acute ischemic syndrome and you don't see ST elevations. If there are ST segment elevations, recognize that not all ST segment elevations are in fact ischemic. And we'll talk in a little bit about some of the other things that produce ST elevations. If the first troponin is negative, well, maybe you're catching a syndrome too early. And ultimately, if somebody genuinely rules out with the current very sensitive troponins we have, the question arises whether this really even is an acute coronary syndrome at all. This is particularly the case outside of the United States, such as in Europe, where there's more uptake of the ultra high sensitivity troponins, where there have even been articles written about a requiem for unstable angina, simply because the absence of elevation in troponin is such a strong negative predictive factor of an acute coronary event. I don't know if Raphael is on the call, but yes, I was able to log in.
Thank you. Yes, I'm here.
So if you have an NSTEMI, and this is one of the juiciest topics that I'm sure occupies more time on your rounds than you'd care to have, is this actually primarily a coronary event, or is somebody just leaking troponin for some other reason? We'll talk about that. And then finally, even if you clinched a diagnosis of ST elevation MI, maybe this is somebody that doesn't get the knee-jerk response of rushing to the cath lab or dual antiplatelet therapy. There are cases where you really need to think carefully about the goals of care of an individual. So the first thing I want to get into is this patient with chest pain really having an acute coronary syndrome? So there's a certain cartoon perspective and perception of acute coronary syndromes in our minds that's ably captured here by Frank Netter. But I think as we've come to appreciate, not everybody with a myocardial infarction shows up the same way. And some humility in history taking and physical examination is really important. So many of you have likely seen the JAMA Rational Clinical Examination series, which is a really cool set of articles in evidence-based medicine that looks at classical teachings in history and physical examination and asks, well, that's all well and good, and white-haired professors have told me this, but does it really actually pan out when you put physical findings to the test of the evidence? So on the left-hand column, what you'll see is a number of historical findings or physical findings. And in the right-hand columns, what you see here are the positive and negative predictive values associated with each of those findings in isolation. And rather than belaboring any one symptom or sign in isolation, I think what's most striking is that none of these has much more than a 20 to 30% predictive value either way. And so anybody who tells you, oh, this patient only had pain radiating to the right shoulder, not to both shoulders, it can't possibly be an acute myocardial infarction, we need to be very cautious in using any one finding as a litmus test. And that, by the way, includes tenderness in the chest or reproducibility, which has not actually panned out as such a reliable finding. Now, a caveat in looking at this type of literature is that it's doing something that's very unnatural. It's looking at individual signs and symptoms in isolation. And I think when any one of us approaches a patient as a whole human being and approaches a story as a complex story, you're really integrating with variance valuation of different findings, all of these data points into one coherent whole. And this ultimately, I think, is what improves our ability as diagnosticians with every additional year and decade that we spend in medicine. We become much better at integrating all these variables that we encounter. And so, in fact, when you do look at diagnostic aids that integrate multiple variables rather than individual findings in isolation, such as the heart score or the Tomey score, these do tend to perform better than those isolated findings. Still by no means perfect, but they certainly do a better job than isolated findings. An example of these just in focus is the Tomey risk score, and this is the one specifically for unstable angina and NSTEMI. The elements that factor into the scoring system are shown in the blue table on the left. And you can see that as you add together these clinical factors, which in general are pretty easy to obtain for any patient with chest pain, the more that you add these factors up, the greater the risk of major adverse events within the next 2 weeks. And specifically, the adverse events we're talking about are death, myocardial infarction, or urgent requirement for revascularization due to severe ischemia. The heart score is one that's growing in use. You may already know actually that our Cardiovascular Institute and our heart health system here at Mount Sinai has adopted universal use of the heart score for patients who are coming in with chest pain syndromes. It has probably the best data of the study of the scores that have been tested in the emergency room environment. And so you're going to increasingly see these scores within the emergency department documentation. Across town and likely soon at our institution, there's going to be a standard of quality that every patient admitted with a chest pain syndrome should have a heart score documented. And you can see here that as your heart score goes up, there's a strong and direct relationship with your risk of heart attack, PCI, bypass surgery, and death. Among the different scores, the heart score, as I was saying, seems to maybe perform marginally better than other scores such as the Tomey risk score or the GRACE score. Sorry, having a sluggish connection here. When there's uncertainty, and in particular when you have ruled out a patient with cardiac biomarkers, a very useful tool that I think that our center does a nice job of employing is coronary CT angiography. This is a test that can have different potential uses, and at this moment I'm referring to it exclusively in the context of the patient with an undifferentiated chest pain syndrome. In a study called the ROMI-CAT study, ROMI-CAT 2 specifically, the question was, if you use coronary CTA as part of your routine strategy for troponin-negative chest pain patients, as opposed to our routine care that maybe involves stress testing or otherwise, what impact does this have on the amount of time that you're spending in the emergency department? And interestingly, you end up spending a lot less time waiting for decisions if you move early to a CTA in these patients. Now, what you trade for time waiting for a decision, however, you pay for in terms of an increased utilization of certain other types of cardiovascular testing. So it has yet to be clear that this is a resource-sparing strategy. If anything, it potentially could lead to an increase in resource utilization. But I think the study was fairly clear that it led to an earlier definitive answer as to the presence or absence of important coronary artery disease. So we're speaking about non-ST elevation ACS now. And so the question is, are you sure that there aren't any ST segment elevations? So this comes down to how you look at ST segments. So when we're speaking about the ST segment and whether or not it's elevated, bear in mind that that needs to be elevated in relationship to a certain reference point. The reference point here is the TP segment. And so this is between the end of the preceding T wave and the preceding P wave. Now, some on the call may have had rounds with me in the past where we spoke a little bit about the paradox of ST segment elevation or depression. And that, as I mentioned before, it's that the ST segment is elevated relative to the TP segment. But interestingly, what's actually happening in these cases is not a movement of the ST segment, but it's rather a movement of the TP segment. And so what we call an ST elevation MI actually is a result of a depression of the TP segment. so that the ST segment, being exactly where it always was and always will be, simply appears more elevated relative to the depressed TP segment. And the converse is true in ST depression ischemic syndromes. What's actually happening is that the TP segment is becoming elevated, and relative to that, the ST. And this pertains to how the vectors of injury currents appear to different leads. Fully deriving that is beyond the scope of today, but hit me up if you ever want to talk about TP depressions. So as we mentioned, selected thrombotic total occlusions can present with no apparent ST elevations on a standard 12-lead EKG. And so then the existential question arises, are these NSTEMIs or are these really STEMIs? So from a coding perspective, from a documentation perspective, in the absence of ST segment elevations, these are NSTEMIs. But what's going on biologically? These are patients who presumably have acute total occlusion of a large vessel by thrombus. The myocardium doesn't care what the EKG looks like, and the severity of ischemia, the acuity of ischemia, and the transmural extent of ischemia is going to be much more akin to that of a STEMI than it is to an NSTEMI. And accordingly, the urgency of our revascularization and the risks of complications are going to more closely parallel those of STEMI than of NSTEMI. So we spoke about how troponins are elevated all over the place. And so the question is the patient that you're meeting with an elevated troponin having an acute myocardial infarction? So the clinician approaches the conversation about acute coronary syndromes from the order of, is there a syndrome of chest pain? Then what does the EKG show in the troponin? All too often, as physicians, and in particular as cardiologists, what we're faced with is kind of a backwards question. My patient has an elevated troponin. Are they having an acute coronary syndrome? And so some of the most recent universal definitions of acute myocardial infarction, in a sense that they're helpful with this because they look at the problem from the perspective of the troponin itself. They're saying, okay, this patient is having an acute rise and fall in troponin. Is this an acute myocardial infarction? And so looking at this algorithm, really the way that this problem is thought through is, if you have an acute rise and fall in troponin, the question is this or is it not accompanied by an acute coronary syndrome? And by that, I mean some evidence of an acute ischemic syndrome. That could either be typical chest pain. It could be ST segment deviations, either elevated or depressed. It could be wall motion abnormalities on an echocardiogram that correspond to a territory that would become ischemic. Plus minus, and this is not as ingrained in the language of the paper, if you're having new ventricular arrhythmias, that could certainly be very suggestive of an acute ischemic syndrome. Any of these or multiple of them would serve as evidence that a patient is having an acute myocardial infarction. If you have the rise and fall in troponin, but you don't have any of the acute coronary syndrome, what you're left with is an acute myocardial injury. And from there, then you can go down different pathways. So for the acute MIs, there are different types of MIs, and we'll get into that. But acute myocardial injury is typically reflective of some other process that's not actually imposing an ischemic burden upon the heart. It's debatable whether or not this really is demand ischemia, so to speak, although that's what our guidelines and the EPIC coding system requires us to write, because it's not explicitly ischemia per se that's causing this leakage of troponin. You could have a completely non-ischemic syndrome that's bringing about this leakage of troponin, like a myocarditis or acute heart failure. An argument could be made that there's some dimension of ischemia that's component to that, but strictly speaking, a pure acute myocardial injury is not demand ischemia. There are some patients that we care for who will always have a troponin that's elevated no matter what's going on. And this is not actually an acute rise and fall, it's just always elevated. So perhaps a patient who has end-stage renal failure on dialysis, or somebody with significant structural heart disease. And that's none of the prior mentioned entities, but rather a chronic myocardial injury. I won't go into the details of this, but suffice it to say, there's a long list of clinical entities that can be associated with abnormalities of serum troponin. Effectively, if you can think of it, you could get a positive troponin. Now, in the context of an acute myocardial infarction, there is a typical pattern and kinetics of the rise and fall in troponin. And so here's a schematic graph that depicts how the troponin tends to evolve over hours after the onset of an ischemic event. There's going to be an initial sub-detection rise of troponin, and depending on the sensitivity of your troponin assay, you may or may not appreciate this early rise before it gets above the 99th percentile, the upper reference limit of normal. It's going to continue to rise until it plateaus and then slowly downtrends. And you can see here that the complete washout of troponin is much, much slower than the initial acute rise. And so checking troponins for days after a presenting event, it will generally continue to be positive, although we hope on a downward trend. This pattern of kinetics is important as you're trying to sort out chest pain type symptoms in the aftermath of, for example, a treated myocardial infarction, because the patient will invariably still have an elevated troponin, and it may not be reliable to compare the next troponin to the preceding one because you still may be within the rise of the first acute event. Other assays such as CKMB have sort of fallen into disfavor, but I will tell you, in understanding the kinetics of ischemia and whether you're having a recurrent ischemic event or something called a reinfarction, CKMB can be very useful as a second perspective on the evolution of ischemia. So the height of the troponin matters, and it's a nice quantitative way of estimating the size of a myocardial infarction. On the screen here, what you're seeing is a correlation between the troponin level measured at various time points, day 1, day 2, day 3, or the overall peak, versus the size of an infarct as measured by SPECT. Now, SPECT is a little bit of a lower resolution imaging tool, and so it's not a very, very tight correlation, but there is a correlation that exists by SPECT, which is a nuclear test, between the height of the troponin and the size of the infarct. We can get a much tighter correlation looking at the higher resolution imaging tool, cardiac MRI. And you see here that depending on which time point that you're looking at of the troponin, there's a very, very tight correlation between the height of the troponin and the size of the myocardial infarction. And so it's important to appreciate the peak of the troponin in so much as it gives you an estimate of the size of an infarction. So as we alluded to before, there's more than one type of myocardial infarction. We think in terms of the soap opera version of myocardial infarction of one particular pathobiology. But the reality is that there's a great deal of diversity among the different types of acute myocardial infarction. And it matters to know which type it is, because we're going to treat one of these very differently from another. As a practical matter, a big part of this is the role of antithrombotic therapies. And so I'll present to you two potential examples. So you have one patient who had a ruptured atherosclerotic plaque in their LAD and now has a thrombus in the coronary artery. And then you have another patient who has chronic calcified coronary artery disease who develops a massive gastrointestinal hemorrhage. Which one of these patients should you heparinize? So-called type 1 myocardial infarctions are defined by the presence of an acute thrombosis within a coronary artery. No matter which of the pathologies you encounter, what unifies these is that there is thrombus that forms inside of a coronary artery. Now, most often this is caused by the rupture of an atherosclerotic plaque, but there are some less common entities such as plaque erosion or calcified nodules that can also precipitate thrombi inside the coronary arteries. All of these are type 1 myocardial infarctions. Type 2 myocardial infarctions are characterized by an acute imbalance between myocardial oxygen supply and demand, and none of these entities has the formation of a thrombus inside of a coronary artery. Now, it encompasses a whole variety of anatomic findings, which can include chronic atherosclerotic plaque, could include vasospasm, spontaneous or iatrogenic coronary dissection, or even normal appearing coronary arteries. All of these could actually be associated with type 2 myocardial infarction if the circumstances of supply and demand are such as to fall beneath the ability of the coronaries to auto-regulate delivery of oxygen to heart muscle. Now, as a thinking exercise, you take a patient with an MI to the cath lab, and you find that there is a thrombus in the distal left circumflex artery, and ultimately you determine that this was an embolism. So would an embolic thrombotic myocardial infarction constitute a type 2 or a type 1 myocardial infarction? Anybody?
You can feel free to unmute yourselves or post in the chat if you guys think this would be a type 1 or type 2. So Salvador's and Galit are saying a type 1.
So does anybody want to make the argument for why type 1?
So Salvador, would you be able to explain your thinking or reasoning behind it?
Yes, I'm going to give it a try.
Excellent.
So if we're talking about an embolic event and it has like a thrombotic component to it, then I think it's more a type 1 compared to a type 2, especially if at some point in the circulation of the coronary arteries, it produces like 100% occlusion, even if it's distal.
So intuitively, we hear thrombus and we think type 1. The thing that I will highlight though, and the reason why it is a type 2, is that what distinguishes type 1 is not the involvement of clot, but rather the fact that that clot formed spontaneously within the coronary artery. And so if you had a thromboembolism to a coronary artery, which in this hypothetical case we proposed, this would be diagnosed as a type 2 MI. And I bring up this example because I think it's the one that often is the biggest sticking point, but it also gets to the root of understanding type 1 versus type 2. It's really a spontaneous thrombus formation within a coronary artery. Does that make sense? So mechanistically, type 2 involves some mismatch between supply and demand. And some of the potential mechanisms are shown here that could explain that. Generally speaking, this is the type of MI where you say it's not the heart's fault. It was just an innocent bystander minding its own business and circumstances were what they were. That doesn't mean that nothing has changed within the heart arteries, such as in the case of dissection or spasm. There may be something anatomic that is different. It's just that it wasn't associated with thrombus forming spontaneously within the artery. So I think sometimes we give type 2 MIs short shrift. We sort of disrespect them. But actually, these are not benign entities by any means. So if you look at the outcomes of what happens to people who show up in the hospital with type 2 myocardial infarctions, it's actually a very, very high risk of death. upwards of a third of patients within 5 years will be dead if they showed up with a type 2 myocardial infarction, a heart attack, or cardiovascular death. When you look at the specific risk of cardiovascular events in these individuals, again, there's a very, very high risk of future cardiovascular events in these patients. Now, whether or not you have coronary artery disease tends to dictate the likelihood of future cardiac events. And so those patients who, one way or the other, are worked up and found not to have significant coronary artery disease, they're still going to be very high-risk patients, although their risk is going to be driven largely by non-cardiovascular mortality. Whereas if you have significant coronary artery disease accompanying your type 2 MI, cardiovascular events will contribute importantly to your major adverse events. So this creates a question and some hypotheses about, well, what should we do about the coronary artery disease in these patients with type 2 MI? Number one, should we go hunting for it? Should we go cathing everybody who shows up with a troponin of 0.5 with their pneumonia? And if you bring them to the cath lab, when you find that 71% stenosis of the distal RCA, should we be stenting that or pursuing revascularization otherwise? Or is that unlikely to meaningfully affect your outcomes? It's far from certain that coronary revascularization for type 2 MI is necessary or indicated, but neither has it been disproven at this point that acting upon that coronary artery disease won't affect your outcomes in a favorable way. So this is a major, major area in need of investigation. And there is some research going on right now that's hoping to get insight into the right answers. So one such trial is the Acute trial, just to keep you on the lookout for this. It's enrolling right now. We don't have any data yet on this, but it's really coming down to the question of, should we pursue an early invasive strategy for patients with type 2 myocardial infarctions, with physician discretion at that point as to whether or not there's a role for PCI or otherwise. But basically talking about the role of a routine strategy of an invasive angiography in patients with type 2 MIs. So stay tuned for this. I think that this will be an important study in how we deal with a lot of our patients on internal medicine services. There are more MIs than type 1 and type 2. This is the full list of the subtypes of MI that are listed in the universal definition. Type 1 and type 2, as we mentioned. Type 3 means that you had sudden death before we had a chance to measure your blood work, so we never actually got to check a troponin. The type 4 MIs are all related to MIs after undergoing percutaneous coronary intervention. And type 5 are MIs that occur within the 2 days after bypass surgery. Now, as we outlined and really underscored for type 1 versus type 2, you can have a wide variety of different biologies underlying these events. And it really behooves us as physicians to make sure that we're providing patients with the right treatment that actually matches the pathobiology of their problem. So as we said in the example before, you're not going to heparinize the patient who has a type 2 MI due to a massive hemorrhage. The corollary to this is that how urgently we proceed to any given intervention is going to be dictated by the acuity of the ACS that a person is coming in with. Now, there are a lot of different ways to do that. And if you're going back and you're studying your manuals, you're reading guidelines to try to get a handle on what's recommended, they have some kind of complex tables for early invasive, immediate invasive, slightly early invasive, you should invade, but not right away. And it gets a little bit murky. And I think it's honestly kind of a false way of dividing things up. It also presumes that ACS is a monolithic presentation. And in reality, what I think most of us have appreciated is that acute coronary syndromes can be very dynamic in how they evolve, even from moment to moment in a hospitalization. And so we need to be prepared to be flexible and to adapt to the needs of a patient's syndrome. So in keeping with that, rather than look at these bins of early versus delayed invasive strategies, I think about my patients clinically, and I consider them in a way that they're able to evolve from one moment to the next. And for the sake of simplicity, I've divided this into 5 axes. I think about a patient's symptoms, their EKG findings, their heart rhythm, their hemodynamics, and their extent of myocardial injury. And from the green to the red on this, you'll see the extremes, in a sense, of what I would consider for any one of these given bars, ranging from lack of symptoms to refractory chest pain, from a normal EKG to ST segment elevations, from normal sinus rhythm to ventricular fibrillation, from stable hemodynamics to cardiogenic shock with decompensated heart failure in between, and from a negative troponin to a positive and rising troponin. And immediately, if you could just imagine a patient who's all in the green or all in the red, you see 2 very different types of patients with 2 very different types of needs to get to aggressive therapy. And I think it's not too difficult to imagine that the patient on the red side is the patient that I'm probably going to be rushing to the cath lab as soon as possible. Whereas a patient who's living more in the world of the green, we could probably be a little deliberate about. We may or may not pursue an invasive strategy, but we have some opportunity at this moment to optimize medicines and pause. So what are these interventions and medical therapies? So there's this concept of MONA, who I guess has been, extended to Mona Bash now, but MONA is the classic teaching with your morphine, oxygen, nitrates, and aspirin. And there are a lot of caveats in that classical teaching. I'll speak first to morphine. For sure, if you give somebody with pain morphine, the pain is going to get better. But the question is, what are we really doing for the biologic cause of that pain? Are we having adverse treatment interactions with other therapies that are to the benefit of treating the actual process? Are we delaying care in any way? And does that have any adverse impact upon hard outcomes? So this has been looked at independently in ST elevation MI and non-ST elevation MI. As of the most recent, but now old STEMI guidelines, morphine remains the drug of choice for pain relief in STEMI. It's considered maybe reasonable for NSTEMI if everything else you're trying is not working. Looking at the data, there's some cause for caution. This is observational, of course, but if you look at patients who received morphine in the CRUSADE registry of non-ST elevation ACS, those patients who got morphine had a higher tendency to in-hospital mortality in a propensity-matched analysis. In STEMI patients, again, there's some concern that in ticagrelor-treated patients, morphine may adversely affect the pharmacokinetics or pharmacodynamics of ticagrelor. And indeed, patients had lower rates of pre-PCI normal blood flow at angiography. And the hypothesis was that this could be representative of less efficacy of the antithrombotic therapy. So take some caution in use of morphine unless there's a very, very good reason for it. How about oxygen? In general, guidelines suggest that we should only give oxygen to patients who need it. Don't give oxygen to patients who aren't hypoxemic. This is probably a good rule of thumb in general, but I think if you take a look around, this would be an interesting QI project within the hospital to discover excess use of oxygen in our patients. And I would bet you would find that we're burning a lot of oxygen that isn't really needed. There are any number of possible adverse effects to superoxia. But in the specific setting of myocardial infarction, there's concern that this could actually precipitate worsened free radical mediated injury and possibly expansion of infarct size in that regard with ischemia and reperfusion. And so there's a randomized study called the AVOID trial that looked at giving normoxemic patients oxygen or placebo, or oxygen or air was the design of the study. And those patients who got oxygen instead of air actually had higher levels of troponin, and raising a concern that their infarct size was actually larger with the extra oxygen. Nitrates can be very useful, both as favorably affecting the physiology and also alleviating symptoms. You could give it sublingually, you can give it as a spray, you can give it as a paste or a patch, or certainly as a drip. And caution is just required for certain subsets of patients based upon the nature of their presenting infarction or their polypharmacology. So specifically, as many of you know, you don't want to combine nitrates with phosphodiesterase inhibitor usage, such as sildenafil or otherwise, which could precipitate very severe hypotension. And patients with right ventricular myocardial infarctions may be susceptible to acute hypotension due to the preload dependence of the right side. So be very careful in any inferior STEMI patient in use of nitroglycerin. Aspirin for the acute management of ACS remains a mainstay with an initial loading dose of either 162 or 325 milligrams. Our guidelines suggest that this should be given promptly upon diagnosis of an acute coronary syndrome. A key take-home point that I would emphasize is that after that first loading dose, there's effectively no reason for ever a patient to be taking more than baby dose aspirin. And now, depending on where you are, in New York, that's 81 milligrams. In other regions, that might be 75 or 100 milligrams. But low dose aspirin is the mainstay for maintenance. This is particularly the case in those patients who are receiving ticagrelor, where there's actually signal toward harm with high dose aspirin in conjunction with ticagrelor. A second antiplatelet is a mainstay of treatment for acute coronary syndromes, and in particular type 1 ACS. Originally, this was a medicine called Ticlid or ticlopidine, but that was removed from the market. That was the first generation because of an unacceptably high rate of TTP. The second generation was clopidogrel or Plavix. And Plavix was safer than Ticlid, but it also suffered from some risk of TTP, but more importantly, pharmacogenetic variability across the population. And polymorphisms in particular in the cytochrome P450 system enzymes are felt to be a major mediator of the metabolism of the clopidogrel prodrug into its active drug. And that's a major driver of hyper-responders versus hypo or non-responders to Plavix. And so you had patients back in the mid-2000s who were completely adherent to their antiplatelet therapy, but still thrombose stents. That was the genesis of the third generation of agents, namely prasugrel and ticagrelor. Prasugrel is the same drug type as clopidogrel. It's a thionopyridine irreversible binder of the platelet P2Y12 receptor. Ticagrelor is a different type of a drug that is not a thionopyridine. It's a competitive antagonist, so it's in a constant state of dynamic equilibrium, associating and disassociating from the P2Y12 receptor. Each of these drugs was compared with clopidogrel in its seminal phase 3 trial that led to their adoption by the FDA. The data comparing the two against one another has been a little bit more limited, although we do now have the benefit of some trials that have compared the two. At this point, I would say that there's not firm guidance or consensus that one is superior to the other. In specific subsets of patients, one may be preferable to the other. Finally, cangrelor is an intravenous P2Y12 inhibitor. It has a very short half-life. It's a reversible competitive antagonist of the P2Y12 receptor. It has the advantage of both being potent and consistent in its potency, but also being something that you could turn off and be back to your baseline levels of reactivity within an hour. So for example, if you have somebody who is imminently going to the operating room, such as for bypass surgery, cangrelor can be a very useful tool to maintain strong P2Y12 inhibition right up until 1 hour before skin incision. I've summarized most of this, so it's available on the slides if anybody wants to review it, but I won't belabor it now. The only point that I'll make is that for the oral agents, if you withhold them for a period of time, you expect the platelet reactivity to get roughly back to normal. For clopidogrel and ticagrelor, that's 5 days. For prasugrel, we tend to wait 7 days before saying that its effects are totally out of the system. I'm going to skip over this for now, but only to say that it's been a source of some debate about, for the patient with non-ST elevation MI, do we have a duty to rush to start our patients on a P2Y12 inhibitor, whether it was Plavix before or Brilinta now? And this has been studied now in a number of randomized studies that provide some light on this, that have tended to chip away at the notion that we absolutely have to start these right away. If you look at the various studies that have asked this question over time, going back to the Credo study, which is in the days of just clopidogrel, the data seem to lend itself a bit more toward a role for early loading with Plavix. This is modified, though, in the sense by the pharmacologic properties of Plavix, which is a little bit slower onset of action. It's a little bit weaker than some of the third-generation agents. And so it became unclear whether these apparent benefits would remain the case for, number one, the more potent rapid onset agents, and number two, in an era where the quality of our stent technology and our stent implantation technique is really superior to what it was 20 years ago. And so we have a much, much lower incidence, for example, of stent thrombosis in 2021 than existed in the late 1990s and early 2000s. And so indeed, as you look at the kind of the history of trials asking this question of early versus not early P2Y12 inhibitor, the data has increasingly suggested that it's not necessary. And if anything, you may just be tying yourself in knots, having an oral agent that's going to be lasting at least 3 to 5 days in your system before you would be able to get rid of its effects. This was one study in focus called the Acute trial, looking at upstream loading with prasugrel and NSTEMI. There was no apparent benefit for ischemic events, but there was an excess risk of bleeding with the early prasugrel. This is a comparison of prasugrel with no preloading versus ticagrelor with preloading in a study called the ISAR React 5 study. And in this case, there was, again, no apparent benefit for reduction in ischemic events with the preloaded ticagrelor as opposed to the not preloaded prasugrel. The bleeding was very similar between the two. Most recently, there was a study called the Dubious study that looked at upstream ticagrelor loading versus downstream third-generation P2Y12, which could either be ticagrelor or prasugrel. And again, here, there was no evident benefit for reduction in ischemic events with the mandatory preloading of ticagrelor. So again, these most recent data, I think, provide a strong argument that none of us should ever feel compelled to shove 180 milligrams of ticagrelor into somebody's mouth in the emergency department before they get upstairs. Now, on the other hand, there's no downside to shoving 80 milligrams of atorvastatin into somebody's mouth as soon as possible. It may actually be beneficial, but there's no penalty for early statin loading. A little caution is required with early treatment with beta blockers on initial presentation. There's distinctly a subset of patients, namely those who have early signs of shock or decompensated heart failure, who are at risk for major adverse outcomes with early and aggressive beta blockade. And so I've listed on the right risk factors for doing poorly with beta blockers. So if you're admitting a patient with an ACS who has any of these factors in the upper right, just be very careful before starting the beta blocker. And I would say really consider, is this patient compensated from a heart failure perspective before I start in with beta blockers? They may be very reliant upon that catecholamine tone to stay compensated. Now, I don't mean to totally throw out beta blockers, which are actually great. And if you select patients carefully, you can actually reduce infarct size by giving early beta blockade. And this is a study that was done in Spain, comparing the cardiac MRIs of patients who did or did not get IV metoprolol in the ambulance on the way to the hospital with anterior STEMIs. Which NSTEMI patients should go to the cath lab and when? for me, it really, again, comes down to these slider bars. The further you are into the red, the earlier I'm going to get you to the cath lab. As a general strategy, the evidence doesn't suggest that we routinely need to bring every NSTEMI patient to the cath lab very early for angiography. But when you look at subgroups of patients with NSTEMI, there are selected features that stand out as tending to favor an earlier invasive strategy. This is from the VERDICT study, and those factors were positive troponins, a high global risk score, and they use the GRACE score, or ST wave changes. So it tends to go together with
Dr. Tomey, I'm not sure if you can hear us. You just froze in the past 30 seconds.
the data now show that there's no penalty for delaying angiography until somebody stabilizes neurologically. So this was shown previously in the COACT study that was published in 2019. And now, more recently, we have a new study called the Tomahawk study that shows effectively the same thing. So in the last moments, I have a few take-home points. First is that acute coronary syndromes are diverse in their pathobiology and clinical presentation. Second, I would encourage you to respect the patient with type 2 MIs, as these are patients that are truly at high risk both for cardiovascular events and for non-cardiovascular mortality. And we need to learn more about how to approach this, but just recognize that many type 2 MI patients have important underlying coronary artery disease. And this CAD is the determining factor in whether or not they'll die from cardiovascular causes. And then finally, the interventions we have available to us, we should assess the acuity of these interventions based upon the acuity of the syndrome that patients come in with. So I think we have maybe a couple minutes left, so I'll stop there. I'm happy to open to any questions.
If anyone has any questions, you can just feel free to unmute yourself or post it in the chat. But thank you so much, Dr. Tomey, for your time and for giving this talk.
My pleasure.
I have a question regarding type 2 MI. I think I would like to know more in practice and day-to-day, what should we do to suspect coronary artery disease in these patients? Because I feel a lot of the patients we see on the floor have type 2 diagnosis, and we just leave it there as a diagnosis without further investigating. And I guess I would like to know, when is it prone for us to investigate more coronary artery disease, or treat it, or just monitor?
Great question. It's an excellent question. So the first thing that I will say is that what you're tending to do is the most appropriate thing, which is once you've recognized that this is a type 2 event, it's devoting your focus to the primary illness, whatever that might be, because that ultimately is the most important thing during that hospitalization. But to your point, I think then there becomes uncertainty. What do I do with that little troponin that I saw? Does this patient obligate more workup? That question is one of the questions being asked by that, for example, ACT-2 study, about whether these are patients that need to be assessed invasively, particularly on an early basis. I think from the ACT-2 study, my expectation is that there's going to be a spectrum of patients within the type 2 MIs. And we may learn to some extent from the subgroup analyses and analysis of predictors within that group. Can we look at any particular variables that make this patient more likely to benefit from the invasive strategy? I might hypothesize that there are certain cut points for troponin that would be more suggestive, like if, and I'm making this up, 5 times the upper limit of normal, 10 times the upper limit of normal, that would be highly suggestive of important coronary artery disease. Anecdotally, I'll say that it's, the patients that tend to have a lot of CAD and a lot of jeopardized myocardium tend to make relatively more troponin than somebody with less extensive disease. But again, I think the data will be needed to say things with certainty. As a general rule, I think it's never wrong to refer these patients for outpatient, if not inpatient, cardiology consultation, because then at least it gets them into the system to say, how do we want to ask this question? And you can make a decision about whether you want to pursue a cardiac cath, which sometimes might make sense, or perhaps a coronary CTA as a non-invasive anatomic test. Once you've made troponin, I tend to be a little bit less interested in a physiologic test like a stress test. Really, the question at that point is the anatomy. How extensive is the CAD? And so for me, it's either going to be a CT or a cath at that point.
Thank you.